Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by our deputy editor, Nick Bostock, to talk about some of the key news stories affecting general practice. Coming up, we're discussing the impact the current list cleaning drive has had on GP practices and explaining why GP leaders have called for a pause in the process amid fears of inappropriate removals and a huge loss of funding for the profession. We're talking about prescribing for obesity after the BMA warned that the funding practices will receive for new QOF targets on this is unlikely to cover the cost of the work involved. And the union warned that some ICBs are cutting back on locally commissioned services related to prescribing Mounjaro since it's been added to the QOF. And we'll be looking at the additional roles reimbursement scheme after we found that millions of pounds earmarked for the scheme went unspent in 2025-26. Our good news story this week is about those GPs who received awards in the King's Birthday Honours List. So Nick, first up, let's talk about list cleaning. I mean, we talked about this last time on the podcast, but this story has moved on quite a lot over the past couple of weeks. So firstly, remind us what list cleaning is and very briefly why this has become such a big story for general practice.
We reported at the start of June that hundreds of thousands of patients had been removed from GP practice lists as part of what NHS England said was a drive to address patient list inflation. So what is list inflation? The BMA says the population registered with GP practices is generally a bit higher than the official population recorded by the Office for National Statistics because of a few factors. People move, there are delays in updating patient details when their circumstances change. Temporary residents or overseas visitors can add to list fluctuation, and it just takes time to process changes. List cleaning, then, is an administrative process to try to reduce the gap between the actual population and the registered population by identifying people who shouldn't still be on practice lists. So this is something that happens all the time. But the reason this is a huge issue right now is that the scale and pace of removals we've seen since the end of last year is unprecedented. I've looked at the NHS data on this, and what that shows is that total registered patients dropped by more than 458,000 across England between the start of November 2025 and the start of June this year. Practices have seen hundreds of patients flagged for removal at a time. Some have seen 10% or more of their entire practice list removed. And the data show list cleaning is actually accelerating. Well over 100,000 patients came off practice lists in the month to the 1st of June alone. So nationally, this means the loss of around £60 million from core funding for general practice, 10% of the entire contract uplift for 2026-27. And it'll translate into big losses from other income streams that are also calculated from registered patients, so PCN, QOF, and other funding. So this is something with huge consequences for the viability of practices. And the BMA has now identified this issue as one of the most significant financial and operational challenges facing general practice this year.
One of the problems with this latest list cleaning drive is the timeframes involved for practices to verify patients before their removal. And those have changed, haven't they? I think we mentioned this last time as well, but you've got some more information about why these timeframes have changed, didn't you, in the last week or so?
Yeah, so the timeframes have changed, and that's a big factor driving up the rate of removals. Until October last year, NHS England would contact a patient to confirm their registration, and if they didn't respond, something called an FP69 flag was attached to their patient record. The GP practice then had 6 months to respond before the patient was actually removed. From October last year, though, the process changed, and the window practices have to respond to one of those FP69 flags was cut to just 3 months. And it's over that period that removals have really rocketed, because not only has this time window been halved, the total number of patients flagged for removal has gone up really sharply. So from a practice's point of view, there are loads more flags to check and far less time to do it in. So what's the justification for this? NHS England estimates that there are about 6 million more patients registered on practice lists than the population according to the Office for National Statistics. NHS England says most patients whose registration is confirmed, so those who turn out not to be so-called ghosts that need actually removing from practice lists are confirmed in the first 3 months of an FP69 window. So its argument is that 6 months is essentially unnecessarily long. It says patients are given 2 months to respond to an NHS and attempt to contact them before they're flagged for removal with an FP69. And it's actually at that point that the 3-month clock starts ticking. So it's effectively 5 months in total from the point where NHS England identifies a registration as needing to be checked to the point where they could actually come off a list. NHS officials also say they're using a more targeted, data-driven approach to identify patients who may have left the country. So the NHS says this is all justified, but from a GP practices perspective, as we've said, it may be the case that in the past, practices have been able to confirm most patients flagged inappropriately for removal within 3 months. But that was when there were far, far fewer flags in total. So in this new context, the argument that 3 months is fine is much harder to back up.
One of the things that you've also looked at over the past couple of weeks is regional variation. So you've looked at how it has affected practices in different parts of England. What did you find there? Which area was most badly affected?
GP practices across the country are seriously affected by this. I mean, that's the first point to be clear about. I've spoken to GPs in the northeast who are losing hundreds of patients, but London is far and away the most significantly affected region. I mentioned that nationally, around 450,000 patients have come off practice lists since November last year. Just over 180,000 of those are in London, so it's 2/5 of the total. I mean, obviously, London has a large population, so you'd expect large numbers of patients to be affected in the capital by anything happening nationally. But in London, 1.6% of patients have been removed. So that's something like 1 in every 63 patients in the whole of the capital, which is a really staggering number. England-wide, about 0.7% have been removed. And across the 7 NHS regions outside London, the level sort of hovers between 0.4% and 0.6% of patients. So London clearly is the hardest hit.
Yeah, you spoke to a practice in London that had been really badly affected by this, didn't you? What did they tell you?
So I spoke to Dr. Tina Agrawal, who's the co-chair of Camden LMC in North London. And she told me that her practice, it's called a museum practice because it's yards from the British Museum, is on track to lose something like 13% of its entire registered list. It's a super popular practice. The most recent GP patient survey found that 99% of its patients are satisfied with their overall experience. That's compared with the national average in the mid-70s. But they could go from a list of about 5,750 patients late last year to 5,000 over the coming weeks. Some patients have come off already. Hundreds more are flagged for removal. And if there's no change, the practice says ultimately it's in trouble. They stand to lose about 1/10 of their total funding. And that obviously has consequences for staff and for the services that the practice can provide. Camden as a whole has been hit hard. Analysis the LMC shared with me shows that 29 out of 31 practices in the area have been affected by list cleaning. More than 9,300 patients have been removed since late last year. Borough-wide, the LMC reckons practices will lose about £1.2 million in global sum funding, and that goes up to 1.6 million once the impact on funding for GP reimbursement, enhanced access, the additional roles reimbursement scheme, ARRS, is all factored in. And when it comes to inappropriate removals, NHS England says there are safeguards to make sure patients with a recent healthcare interaction are not removed inappropriately, such as people with an active prescription or a recent hospital visit. But Dr. Agrawal told me that one practice in Camden had contacted her to say that a 90-year-old patient who'd received a flu jab just a few months earlier was taken off its practice list.
There's no doubt that some of these people who've been flagged for removal are going to be inappropriate. And I think, London-wide LMC is trying to work out the scale of that problem, aren't they? But there are some real concerns that this is affecting particularly vulnerable patients, aren't there?
Yeah, that's right. The BMA and LMCs have called for an urgent review for all of the reasons we've discussed, but they've specifically highlighted the need for an equality impact assessment. BMA says there's been a disproportionate number of FP69s for patients who do not have English as a first language. And we've discussed previously concerns that patients who are elderly, who are young and mobile and may not contact their practice that often, or those who are vulnerable for other reasons, are most at risk of unfair removal from their practice list, with all the knock-on implications that has for continuity of care and management of their health.
A number of LMCs wrote to the Health Secretary last week raising this as a concern, didn't they?
Dozens of LMCs, 74 in total, signed this letter to the Health and Social Care Secretary, flagging concerns about list cleaning. LMCs and GP leaders nationally say they understand the importance of maintaining accurate patient lists. Nobody's saying that, there ought to be patients on practice lists who shouldn't be there. But the LMC letter says the way this current list cleaning process is being implemented is pushing up the risk of genuine, active patients being removed. And they said that, just because someone doesn't respond to a letter doesn't necessarily mean they're not an active patient. I'll just read a chunk of the LMC letter. It said, many patient groups inherently less likely to engage with administrative correspondence, including those with limited English proficiency, low literacy levels, learning disabilities, cognitive impairment, mental health difficulties, housing instability, social deprivation, or general mistrust of unsolicited communications. Others may reasonably mistake such correspondence for junk mail or fraudulent communications and discard it without response. As a result, there's a real risk that the process disproportionately impacts vulnerable and disadvantaged populations, potentially exacerbating existing health inequalities and undermining efforts to improve access to healthcare for those who already face barriers to engagement. And the LMCs then make the point that patients most likely to be removed incorrectly are precisely those least able to navigate re-registration processes, and that these patients also include groups that neighbourhood models that, are supposed to be taking root right now are meant to support.
The BMA has also written to Health Minister Stephen Kinnock about this. They've raised really similar concerns and also questioned where the money that practices were receiving for these patients is going, haven't they?
That's right. I mentioned earlier that the BMA now thinks list cleaning is among the most significant issues facing general practice this year. And his letter says that the scale of funding removed from practices is going to lead to severe cutbacks. And the reason for that is that general practice funding is based on their registered patient lists. So if you suddenly remove large numbers of patients, some perhaps appropriately, some not, what that means is that total funding for general practice goes down. And that reduction in funding means practices can't afford rising costs for staff, for energy bills and other things that have gone up faster than their income from their contract. Practices want that money to be recycled into general practice, potentially through a rise in funding per patient, which practices say is far too low anyway and hasn't kept pace with inflation over the years. But the BMA says it seems to have been set aside for unknown purposes. I mean, the fear being obviously that it'll end up covering costs in another part of the health service, meaning ultimately a sort of reverse left shift. A specialist medical accountant I spoke to, Katie Collin, said the list cleaning process essentially is silent cuts dressed up as housekeeping. And I feel that's quite a neat way to sum up the sense that GPs have of this process generally. So moving on, Emma, you wanted to talk about obesity this week. Why is that?
Yeah, so this is because of some new guidance the BMA GP Committee in England has put out over the past week or so about the obesity targets that were added to the Quality and Outcomes Framework, the QOF, this year. So as part of the GP contract for this deal, 2 new indicators were added to the QOF on obesity. The first relates to referring overweight patients to weight management programmes, and this effectively replaces the weight management enhanced service that practices could sign up to until this year. So the funding for that has effectively been rolled into the QOF and kind of covers that indicator. But the second indicator is more complicated, and that's where the problem's coming, I think. This relates to prescribing weight loss medication. And to get QOF payments for this depends on the percentage of eligible patients who've had a discussion with a clinician and are offered a prescription for weight loss medication and referred to a suitable behavioural support programme. So what we're talking about here is prescribing tirzepatide, or as it's more widely known, Mounjaro, which is its branded name, because That is the GLP-1 medication that's approved by NICE to be prescribed in primary care. So that QOF indicator on prescribing is worth 13 points. And to get the maximum points, you have to cover 80% of those eligible patients. And when we're talking about eligible patients, what we mean is those patients who are allowed to have this medication on the NHS.
What does the BMA guidance say?
The reason the BMA has put out this guidance is because the GP committee says it's got some really serious concerns about the financial viability of these targets. Basically, it warns that it's going to cost practices far more to deliver the work than the money that they will get from the QOF. The thing to remember is to think about the context which all this is happening. This was one of the big things that the government trailed ahead of the contract being announced earlier this year's GP contract. Former Health Secretary Wes Streeting, he's a really big fan of these weight loss medications. He's spoken a lot about how they could be the key to getting people off long-term sick leaves and back into work, and also the role they could play in preventing serious health conditions. I think he really felt that these GLP-1 medications were a potential game changer. So I think this was something that the government was really keen to get into the GP contract this year. But this latest guidance from the BMA is basically warning practices to really look carefully at the figures. And if they decide that it's not financially viable for them, then the BMA says that they shouldn't overtly attempt to chase the points for that indicator. And I guess what that means is that obviously GPs will see patients if they need to be seen and come in and prescribe for patients, but they wouldn't necessarily be actively calling and contacting those patients and trying to hit those high percentages that they would need to get the QOF money. Across both of those obesity targets, that's 18 points in total on offer, and that's worth a maximum of £4,103.10 for an average practice, but obviously some variation on that depending on practice size and prevalence. But it's not very much money really, given the additional work it will involve.
So on that point, how much work is actually involved?
Well, it's a lot. The NHS is in the midst of a 3-year initial rollout of tirzepatide. Back in December 2024, NICE recommended that it should be available to everyone with a BMI of over 35 and at least one weight-related comorbidity. And that is a huge number of people. If that had happened straight away, it would cover 3.4 million people. And that would basically be impossible for the NHS to have done initially. So NHS England applied to NICE for a funding variation to introduce a phased rollout. So we're just about at the start of the second year of a 3-year rollout. And by the end of those 3 years, about 220,000 people will be eligible for the jabs on the NHS. And from GP's point of view, in the context of the QOF, there'll be quite a big expansion on who is eligible from this financial year, so from 2025-26 to 2026-27 to next year. Way more people are going to be eligible from next year. But the funding isn't going to go up because it will probably be the same number of points available next year. So that's the BMA's big concern. The guidance we're talking about says that this year practices could at best break even, but only if they operated under highly constrained conditions with optimised workforce models. So that sounds quite complicated for them to do. And next year, the number of eligible patients, as I said, will go up a lot. The BMA says it will double, and that will leave practices facing an increased financial deficit. The BMA also says that given the complexity of the patients involved, it's going to require quite a lot of clinical input. And that's because the first cohorts eligible for Mounjaro on the NHS are those who have 4 or more comorbidities, and those eligible next year will have 3 or more. So that they are going to be complex patients. And the BMA says that the level of clinical input that will be required is just not reflected in the funding. And the funding also doesn't really reflect the training and admin that practices are going to have to undertake to do this. The thing to remember here is that the QOF is optional. It's part of the GP contract, but practices aren't required to do this. It's optional whether they do this work or not.
The BMA is also worried about what's happening with locally commissioned services, isn't it?
Yeah, I think actually that's one of the big worries about all of this, to be honest. It's not just about the funding in the QOF. In an update to its members, the BMA said it was hearing reports that some ICBs were starting to withdraw locally commissioned services for prescribing and monitoring tirzepatide since these indicators have been added to the QOF. So these are local enhanced services that ICBs have commissioned GPs to deliver around rolling out these medications, because NHS England has obviously made sure ICBs have got some budget to spend to make sure that these drugs are available to patients because they have to, because NICE have told them they have to. So obviously in areas where practices are commissioned to do these services, they're likely to be getting a lot more money than that just over $4,000 they would do under the QOF for this work. So, this is basically a really good example of GPs being potentially expected to do the same amount of work for less money. The BMA actually said it had raised concerns about this issue in particular with NHS England and the government during the consultation for this year's GP contract. And it was said it was really disappointed to see that some ICBs had actually done what they feared they would do, which was withdraw these locally commissioned services.
It's interesting, isn't it? I mean, it just when you think about the service where in some parts of the country there was already something commissioned to pay GPs for a particular service, and then a national version comes along that pays them less. Real echoes of what happened with advice and guidance when initially the government set up an advice and guidance DES in 2025-26, which only ran for a year in the end. But in most of the country, people were expected to use advice and guidance for no money. But some areas had agreed a local enhanced service to pay GPs for each advice and guidance request. And when the national DES came along, it set the price per advice and guidance request at £20. But some of those local deals that practices agreed previously were worth a fair bit more. The national deal effectively undercut the local one and made delivering that service a little bit less sustainable for many of the practices doing it.
Definitely. And the other thing, the BMA pointed out, as I mentioned earlier, the QOF is voluntary. It's designed to reward quality of care. It's not designed to be a tool to commission services. And the BMA's point is, if this is something the government really wants to drive forward and it's serious about doing it equitably, then it should be doing it through a properly resourced enhanced service rather than allocating a handful of points from the QOF and expecting that practices will all just undertake this work. But I also think the real problem is that practices can decide not to actively chase those QOF points, but the fact of the matter is that more and more people are going to become eligible for these drugs on the NHS in the coming years, and they will be coming to their GPs to get these prescriptions, and they will need monitoring. The big question is, should this just be part of core general practice? Or do practices need more funding to deliver this? Arguably, it's the latter. If we're looking at 3.2 million people eventually receiving these drugs on the NHS, that's a huge amount of work, and it does need to be properly resourced. So, Nick, the other story we're going to look at today relates to the additional roles reimbursement scheme and an underspend in 2025-26. What's going on with this?
Our colleague Kimberly Hackett had a look into this with a Freedom of Information request to NHS England. What she found was that more than £81 million in additional roles reimbursement scheme, ARRS funding, was not claimed by PCNs over the last financial year. So that's for 2025-26. The total budget for that financial year, once pay uplifts and so on were factored in, was just over £1.71 billion. And the total amount claimed came to about £1.63 billion. So more than £81 million unclaimed. ARRS money is funding that PCNs can use to pay for staff. Until a couple of years ago, that didn't include GPs. It now does. But ultimately, what this means is that a tranche of funding available to support recruitment of staff into primary care hasn't been used. To break it down a bit, if the unspent ARRS money was divided equally between practices in England, it would come to about £13,000 each. So that could mean an extra GP session a week, or maybe a bit less when you include on-costs for each practice in the country. It's a substantial amount of money. Kimberly did a similar FOI request last year, and one thing we can see from comparing the two is that the total ARRS underspend for 2025-26 is actually roughly the same as the previous year in cash terms. So the 2024-25 underspend was about £84 million. But in 24-25, the total budget was a bit smaller. So the fact that the underspend has dropped a bit and that it comes from a larger total budget last year means PCNs claimed closer to the available total in 2025-26. So they're doing a slightly better job of using the funding available to them.
So what actually happens to that money? I mean, this is obviously money that's earmarked for general practice. So what happens to it if PCNs don't spend it?
GPs told Kimberly that they wanted to see the funding remain in general practice until 2025. Unspent ARRS money was actually clawed back by the Treasury, so it was lost entirely to the NHS budget. It now stays in regional NHS budgets, but there's actually no guarantee that it'll go into general practice. Not all areas have a big underspend to play with, but for those that do, practices might hope to see that money recycled into local enhanced services of some sort, or maybe even used to support neighbourhood plans so that ultimately it comes back into practice funding. Although, as I said, there are no guarantees. It is something that LMCs could lobby for.
There's also a regional breakdown of the underspend. What does that tell us? Are some areas underspent more than others? And is there likely, to be a reason for that?
So working out the numbers on this is a bit messy because some ICBs merged and changed from April this year. And we were given underspend figures broken down by the new ICB areas. But just looking at ICBs that didn't change, most of the underspend seemed to have been in the single figures percentage-wise, although one or two appears to have larger underspends. Understanding why that might be is tough, but in some cases it could just reflect the fact that some parts of the country struggle to attract the clinical staff. And it can also be that, it's just difficult to get people to move to some parts of the country. It's perhaps also because of the funding available through the ARRS, which often GPs say is just not enough to provide an attractive salary. Just to put this in context, we know that there's, we've been reporting on it for some months, that, years even, that there's significant underemployment in general practice. We know that many GPs are either unable to find work or unable to find as much work as they want. So to know that there's this big block, £81 million of funding available essentially to general practice, all of which now can be used to recruit GPs, to know that that funding's there and it hasn't been able to be spent on recruiting GPs is particularly frustrating.
Before we go, we've just got time for our good news story, which this week is about the GPs who received awards in the King's Birthday Honours lists. And it's a really impressive list of GPs who've made a real difference to their local communities. Former BMA GP Committee Chair and former RCGP President Dr Richard Vaughtry was awarded a CBE for services to general practice. Dr Azar Chowdhury, who was awarded an MBE for services to the community in Peterborough. Dr Deborah Faint received an MBE for services to general practice for people experiencing homelessness in Liverpool. And South London GP Dr Tyrrell Evans received a British Empire Medal for services to palliative care. Meanwhile, Dr Michael Dixon, who's been a GP in Devon for over 40 years and was head of the Royal Medical Household until this month, was personally honoured by the King and becomes a Knight Commander of the Royal Victorian Order. There's much more about the work these GPs have been recognised for in the story about this on our website, and we'll put a link to that in the notes for this episode. Well, that's it for this week. Thanks for listening, and thanks again to Nick. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.